is Julie Silence, and I am from Homebase, and we are here today to talk a little bit about some new materials that we have to support COCs as they work, continuing to do their work on the Housing and Homelessness Incentive Program. So first slide. For those of you who don't know about Homebase, this is our team who works across homelessness and housing. And Homebase is a nonprofit organization working for over almost 40 years to prevent and end homelessness. We do federal TA, state TA. We work side by side with local organizations, counties, cities, and nonprofits. And we've been doing quite a bit of work over the last number of years, specifically in California, on partnerships between healthcare and homeless systems of care. And part of that is this project that we're doing around this incentive fund of the Housing and Homeless program. So looking forward to sharing with you some of our new materials and sharing a little bit about our materials we already have in place. So next slide. Today, we're going to talk about the toolkit, just introduce you to the toolkit. And then we're going to go over a couple of some of the key tools in the toolkit that we think are of most interest to you all or are worth at least going through an explainer. So we're going to talk a little bit about understanding the HHIP performance metrics that the Department of Healthcare Services requires. We're going to talk a little bit about maximizing the enhanced care management and community support programs that are now new under CalAIM. And then we're going to talk a little bit about expenditure planning and then leave some time at the end for Q&A. Our intention with this webinar is to introduce these materials, give you all some time to take in the materials, and then offer some free office hours on April 20th and 26th. And we'll have more information in the chat and at the end of this presentation about how to access those office hours. And the idea is if you have questions or if you're having a particular trouble with an issue and you just want to talk through with the Homebase team, you're welcome to join those office hours. One is this week and one is next week. Next slide. So the HHIP implementation toolkit will be out either today or tomorrow on our website. Go to the next slide. And it's in the context of a larger project that I spoke about before. So our website is homebaseccc.org. And then all these materials are on our healthcare resource page. And you'll see that in red at the bottom of this. In August of 2022, Homebase put together some basic overview materials for COCs to help better understand some of the new housing related benefits under CalAIM. And so we wrote an overview of CalAIM, a little bit on the 3 housing related services that you see on the community supports and HHIP, and then a more in-depth fact sheet on HHIP. And as the work progressed, we do some TA on the ground, and it became clear that communities and COCs and counties would benefit from some more detailed guidance and tools to maximize their partnerships with the managed care plans. So we recently put together our new toolkit, which is next slide. And this new implementation toolkit has, I think, 7 or 8 different tools. You can get it all in one long PDF, or you can just shop for an individual tool if you just want one of them. And so we'll do the next slide, which has a little bit more clear. They're fancy, but can't see the reading on them when you're in a PowerPoint. So we have 8 different pieces to the toolkit. The first one is Fundamentals of Homelessness Response for Managed Care Plans. And that's something that just gives an overview of homelessness, the homeless system of care, and particularly coordinated entry that you all can share with the managed care plan partners, often who don't fully understand how the system works. Another is understanding HHIP performance metrics, and so on and so on. So you can see here and read for yourself what the list is of each of the tools. And today we're going to focus first on the understanding HHIP performance metrics. And then we'll go a little bit into the ECM and community supports, spend some time at the end talking about expenditure planning, which is really the long-term investment, And then we'll highlight a few of the data sharing and data tools that we developed just to kind of flag for you all. And I think that is my turn to pass over to Irina.
Thanks, Julie. So what are the performance metrics and why are we talking about them? In order to receive HIP incentive funds, MCPs must report to DHCS at least twice, right? So there are 2 different measurement periods and 2 different reporting dates, and a set of metrics that they're supposed to report on. And of course, the better they do on those metrics, the more points they get, the more funding they're able to draw down. So the 2 performance or measurement periods were from May 2022 through December 2022, and that reporting was done on March 10th. So that one's already passed. And so the next set of measures are due at December 2023 at the end of this year, and they will cover January 2023 through October 2023. So we are now in that measurement period. And so we thought this would be a good opportunity to talk about sort of what to look forward to while we still have time to work on these measures together with MCPs. There are about 15 or 16 measures total. There's some of them are high priority. Jillian, if you can switch the slide, please. So these are all of the measurements for period 2. The ones that are highlighted in red are the priority, which just means that DHCS will be paying particular attention to those. Those may have additional points or additional narratives. Points are assigned either based on performance. So in some of them, data is required to report how well you did in comparison to your previous reporting period. Some of them are narrative based, describing sort of the process that you're going through or partnerships that you've created and how they work. Again, we'll only go over the highlighted, the red ones. Those are the priority ones. If you want to see more detail about each of the metrics, they are in the toolkit that will be published soon, and really break down in detail, like what does each measurement mean, how to calculate it. Certain of these measures require certain formulas, and so you can walk through those in the toolkit that will be published. I see there's a question in the chat. Sorry, I got distracted by that question. In 1.3, what is CS an abbreviation of? Excellent question. If I ever mention an abbreviation that you're not familiar with, please stop me. It is community supports. It is services, housing related support services that are available through MCPs. And so homeless services providers can connect their clients who are MCP members to those services to receive like housing navigation. Sometimes it's things like deposits and so forth. And I think we actually have a little bit of that information towards the end of the presentation. So I don't want to go too deeply into that. Let me see if there's anything else. So really kind of focusing on what the metrics are and how can COCs help, how can they work with MCPs to sort of do really well on these metrics to draw down sort of the maximum amount of funding that is available and possible. Next slide, please. So the first one we're highlighting is metric 1.2. It's connection and integration with the local coordinated entry system. This is something that was also part of the measurement 1 period, and MCPs and COCs should have been working on this together already to kind of bring the MCPs into the coordinated entry system processes so that they know and understand how coordinated entry system works. Some MCPs have already tried exploring whether they can become access points to coordinated entry. And so this just goes sort of deeper into that and asks whether there's been any changes to the coordinated entry process based on the collaboration between MCPs and COCs, whether the prioritization changed, are health risks being taken into account, have you revised your processes or policies and procedures around assessment and prioritization based on your collaboration with MCPs? So this is a pay for reporting metric, which means there's no data required. You are required, or MCPs will be required to provide an explanation narrative about this work, and points are assigned based on the narrative. How the COCs can help is just really collaborating around coordinated entry, including your MCPs in the coordinated entry committees. If you're in the process of revising your coordinated entry policies and procedures, and even if you're not, this may be a good time to reassess your prioritization, your assessment, and really collaborate with MCPs to make sure that health risks and vulnerabilities are taken into account in your coordinated entry system. And again, if it makes sense for both the MCPs and the COCs, explore having MCPs as access points to your coordinated entry system, and whether that means an actual access point or something less than that. Perhaps they are assessors and they know how to do assessments and connect to HMIS, but they're not widely open to the public. So it really varies from community to community, and just really explore that connection between MCPs and coordinated entry and what that means for you. Next slide. The next metric that we want to highlight is metric 1.4, and that is partnerships with counties or COCs and other agencies with which MCPs have data sharing agreements and can share information about their housing, about the housing status of their members with each other. So this is really where the data sharing starts. You will see there are a lot of data sharing requirements and measurements throughout the metrics. This one really has to do with getting data from the contracted agency. So whoever MCPs are contracting with to provide housing services, are they able to get housing status data back from those agencies or COCs? Is there, are they able to flag when housing status is changing for their members? Are they doing data match between HMIS and MCP data? And this is a pay for performance metrics, which means you have to show that at least 75%, the MCPs have to show that at least 75% of the providers the MCP is contracted with can share data with MCPs. There is, I don't think there's an additional narrative. I think that's just the data. How can COCs help? It's, working around those agreements about what kind of data is shared, how often, ironing out that language and getting everyone on the same page and figuring out what that looks like, how to share data safely and securely. We do have in the toolkit a couple of tools that have to do with data. One is a sample kind of agreement that provides some language that is really for you to sort through and figure out which of that language makes sense for you to include in the agreement. Getting all the MCPs, if you have more than one in your community, getting them all on the same page about what that sharing looks like, what kind of data they need, what you can provide, and how to do it safely. There's a question in the chat. All right, I see how that's being answered. If there are additional questions, please stop me and let me know.
Irina, we can do that. We can respond and we'll let you know, so you don't have to worry about the chat. We'll interrupt you.
All right. So again, COCs and MCPs can really work together to finalize language in those agreements and figure out what data points are to be shared. And then the higher level sort of data sharing is the the notification of the change of the housing status for MCP members. And that's something that we're going to talk a little bit more about later on, I believe. Next slide, please. Metric 2.1 is connection with street medicine team to provide healthcare to individuals who are homeless. And that is really just what it sounds like is, are MCPs working with the street medicine programs in the COC communities? If there isn't one, are you taking steps to create a program together? Are you connecting the MCPs, the street medicine, and the COC? Sort of, are those connections there? This is a pay for performance metrics, which means that you have to report. Again, the MCPs must report that there's a 10% increase compared to the measurement 1 period, which means a 10% increase in the number of people who are experiencing homelessness, who are getting services through street medicine. And so the COC can really support MCPs and support their homeless population or their street homeless population by really enhancing those connections between the MCPs and the street medicine in communities where street medicine already exists. And in communities where that is not currently a program that you're running, really try to connect your medical providers, your MCPs and the COCs, set aside funding for that from HIP, and see how you can how close you can get to actual street medicine. Next slide.
Can I interrupt just for a sec? The rules from DHCS for rural communities around street medicine are different because the expectation that there's already existing street medicine programs is a little lower in rural communities. And so if you're in a rural community that doesn't have street medicine, I think they're more open to creative ways that you're doing those partnerships that might not be fully integrating into a street medicine team. So don't underestimate if you're doing just a teeny tiny bit that might be worth sharing and building stronger with your managed care plan.
All right, next slide. Thank you. So 2.2 is MCP connection with the local HMIS system. Again, this is all about data sharing. How well are your MCPs connected to your HMIS data? Are they able to receive timely alerts when the status of a housing status of a member changes? And so this is a lot of communities struggle with this. It's a process. It looks a little bit different in every community, but really working towards what is it going to look like for MCPs to receive timely data? Is that, regular updates? Is that, right? Like, who do you need to involve? Is this your IT? Is this your legal department who needs to iron out those agreements? And so that's the work between the COC and the MCP that is, I think, a challenge for a lot of communities. But it is required and it is a priority measure. And there are points for this performance as well as a narrative required. So there's a lot of DHCS is paying a lot of attention to this. Next slide. Metric 3.4, MCP members experiencing homelessness receiving at least one housing related community supports. So here DHCS is looking for the percent of MCP members experiencing homelessness who are receiving at least one of the offered housing related coordinated community support services. So various communities, MCPs will offer different services. So just really knowing what those are in your community and how to tap into them, how to create those referral pathways, and how to get information back about how those referrals are going. And this is a pay for performance metric, which means some data is required. And what we're looking for here is 5% increase from either the local housing plan that was submitted sort of at the beginning of HHIP program, or over the first measurement period, whichever of the two is higher. And so the COCs can work with MCPs to really educate providers about the services that are available and pull those resources together to provide smooth referral pathways, following up on those referrals, and just really making sure that data is also captured, right? So HMIS and MCP's data, quality about sort of what referrals have been made, how they're going, were they able to stick, and so forth. And so really just following up and having the feedback loop on that as well. Next slide. 3.5, MCP members who were successfully housed. So this is MCP members who were able to get housed within during the 10 months measurement period, and that's January through October 2023, who were housed during that period. In order to receive full points, MCPs need to show a 25% improvement from submission 1 period. If they're not able to show that, but can show significant improvement, they will receive partial points. The work between the COC and MCPs here is, again, really around sharing data, as well as providing the housing supports that are needed to maintain housing and get people housed. So we heard that a lot of communities, even though they're they feel like they're housing individuals, that data is just not being captured. So really working on HMIS data quality, as well as feeding that data to MCP providers as well, will help improve that, as well as connecting MCPs to the services already available, as well as connecting your local providers to the community support services that MCPs provide. So having that sort of go both ways to support your clients in getting housing. Next slide. And this is sort of to dovetail on the previous one, is this is once you've housed members, how many of them are able to stay successfully housed in the long term. And so this is the percent of MCP members experiencing homelessness who were successfully housed during the first 4 months of 2022, who are still housed in October 2023. And there's a secondary measure that is percent of members experiencing homelessness who were housed in that second part of 2022, so that May through December 2022, who are still housed in October 2023. Right. And the tool really walks you through like the formula and all the data points that MCPs need to report on. Again, this is a pay for performance metric. So MCPs will need to show that they at least an 85% to receive full points, and partial points will be awarded for significant achievement that is less than 85%. Again, the formula and more details are in the toolkit. There is an additional narrative that asks you to describe the method the MCPs use to keep people housed. And so really working between the COC and the MCP is around connecting the two systems and connecting what one system has to offer to support people who are being housed sort of across the board, right? Like what services are available in the community that we can offer to MCP members, as well as what MCPs have to offer in terms of housing related services to support long-term housing stability. I think that's all I have for the metrics that we wanted to highlight. I will stop for questions. I see that Jillian and Julie have been answering questions in the chat, but if you have any additional questions, please feel free to unmute yourself and ask questions.
Yeah, I think while we're waiting to see if other folks have questions, it might be helpful to answer that question aloud too, just for folks who aren't following in the chat. But we did get a question about how you can know what providers your local managed care plans have contracted with to provide the housing related community supports, and also who are ECM providers in your community as well. The answer is the same. Basically, there is information on some managed care plan websites about who their community supports providers are and who their ECM providers are. I have tried looking for that sometimes, and it is just as frustrating as it is when you look for any information on a health plan's website. So what we would recommend is just to reach out, excuse me, to your local managed care plans and just ask them to provide you a list with who they've contracted with, and particularly not just who their contracted providers are, but which community supports, if they're community supports providers, they're actually providing. Because as we mentioned, in the next section, we're going to talk a tiny bit more about community supports, but there are 14 of them, and most providers are not going to be providing all 14 of them because they're variant enough that some providers will provide some and not others. So just asking for the list, and it will probably change. And so figuring out a way with your health plan to get an updated list when it gets updated would be really useful as well.
Just one more comment about that. We've seen it work very differently in different communities. So some communities, for example, pretty much all of their housing services providers are contracted community services providers. And in some communities, it's very, very limited and limited number of providers who have nothing to do with the local COC, for example. And so again, just working with your local health plans to figure out what that looks like on your community level is really key here.
Yeah, thanks, Serena. At least one other community I'm in, there are very few of the community supports providers are involved with the homeless response system or the COC. So Irina's absolutely right. It will vary quite a lot. I don't see any other questions in the chat. Does anyone else have questions about the metrics before we move into the next topic? We're going to keep up this after each topic. We'll pause for questions about it, and then we'll also have time at the end. I think we'll probably have plenty of time at the end for questions as well. I don't think since this is we have up to 90 minutes for this webinar, I think we'll have plenty of time for questions. So you're not losing your chance to ask about metrics, but we will pause after each topic to see if folks have questions as we go. All right, I think I'm going to move us into the next topic. So as Julie mentioned earlier, the next tool that we're going to kind of focus on the content of is maximizing enhanced care management and community support. So this is where we'll give a little bit more information about what those community supports are. And Julie also put in the chat a resource that was part of the original toolkit that she mentioned at the top of this webinar, that provides an overview of enhanced care management community support. So that tool is linked in the chat if you want to get even more detail than what I'm about to go over. So again, this is just sort of a very brief kind of reminder for some people, or kind of might be new information for other folks about what enhanced care management and community supports are. They're both Medi-Cal programs. Enhanced care management is a Medi-Cal benefit that all Medi-Cal managed care plans are required to offer. It's meant for Medi-Cal members that have complex care needs. And it's essentially a really intensive care coordination benefit with services across multiple systems to help address both the clinical and the non-clinical needs of folks who are Medi-Cal members, so people who are enrolled in Medi-Cal. So this would likely apply to a lot of folks that are experiencing homelessness, especially unsheltered homelessness. We found that many people enrolled in Medi-Cal who are experiencing homelessness are eligible for this benefit. So it involves things like requiring the ECM providers to meet members where they are in their communities. So not requiring folks to like come into the doctor's office, for example, but it requires meeting folks at where they are, whether that's shelter on the street or in their homes. So it's a really great benefit from that perspective. The kind of primary piece of it is that every person who's enrolled would get assigned a care manager who's meant to help each member like set really clear goals, ensure they're actually receiving the full array of benefits that they might be eligible for. And also to not just in terms of Medi-Cal benefits and services, but also to coordinate across systems. So they're meant to really like be a care coordinator that goes outside of the health system and kind of connects to other services as well. So it can be a really powerful benefit once it's sort of fully implemented and folks are connected with their care managers. And that one other key thing we want to note is that relates to the sort of topic of how to really leverage this benefit is anyone can refer a Medi-Cal member for enhanced care management. So it doesn't have to be a doctor, for example, or someone in the healthcare system that refers a Medi-Cal member to this benefit. It can be you if you're working with them. It can be providers. Someone can refer themselves. So it's really open. It's meant to facilitate like referrals so that people can get this benefit. So that's a really key thing to note is that all of you, to the extent you're working with folks experiencing homelessness that are enrolled in Medi-Cal, can help make these referrals. Community supports is the other program that we want to specifically mention. It's another Medi-Cal program. This is voluntary, but every health plan in the state, I believe, is at least offering some of these, and most of them are offering quite a number of them. So managed care plans can provide up to like as many of these 14 services as possible. There are several that are more focused specifically on housing. So like housing. So you'll see the term in some of our materials and just elsewhere, housing related community supports. So that's referring to things like the housing transition, like navigation services, the tenancy and sustaining services, housing deposits, things like that. There's several of these 14 are more closely housing related. So again, these are services that MCPs would contract with providers, as we've kind of been talking about, to provide. And so figuring out which services your local MCPs are offering and then who the providers are that are providing them will be really great for you to know. So we really want to highlight, and that's in this tool, in the toolkit, is really focused on COCs and MCPs being really critical partners in working to make sure as many people as possible are connected to this benefit and these services, the ECM and community supports, to really support folks being able to not just connect to all the different resources they have, but especially to make sure that they're getting connected to housing related resources so they can exit homelessness and then be successful in their housing. So in terms of thinking about SCOCs and MCPs as partners in this work, we have a couple of kind of key things to just mention that COCs can contribute to this and that MCPs can contribute on the other hand. So SCOC providers, which we can ask folks, if anyone's not from the COC side and wants to share in the chat, if you're from an MCP, that'd be great, but I'm presuming otherwise that most, if not all of you, are more on the homeless response side. So in terms of COC partners, making sure that you're aware of the folks that you're working with, making sure folks are enrolled in Medi-Cal, and when they are, seeing if they're eligible for enhanced care management or community supports, and making sure you're identifying folks to get referred to help actually make the referrals to Medi-Cal plans for these two this benefit in these services to ECM and CS. And as I mentioned, if folks are not enrolled in Medi-Cal at all, to make sure that they're getting enrolled if they're eligible. The only real requirement in order to get referred to ECM and community supports is that you're enrolled in Medi-Cal and that you're connected to a health plan that's your Medi-Cal provider. So making sure that folks who would be eligible for these benefits are actually enrolled in Medi-Cal in the first place is really critical too. Excuse me. And on the flip side, MCPs can really make sure that they're leveraging this Medi-Cal funding and these resources to pay for as many housing related services as possible that are, among the community supports. For example, like housing navigation and housing deposits are big ones, to really make sure that, the COC's really limited funding often can be kind of kept and used for other services. So for example, if you're working with someone who would be eligible for the housing deposit community support, let's try to make sure that they're connected to that on the MCP side so that that funding is coming from the managed care plans and not coming out of the COC's funding. The other thing I'll mention, as far as it's not on the slide, but that MCPs can do, is making sure that it's kind of the flip side, is that in the same way that we're suggesting that COCs kind of help to make sure that you're identifying eligible members and making those referrals. This is not quite exactly related to this, but sort of on the flip side, having your health plans make sure that they're connecting with as many of their members that they know or suspect are experiencing homelessness, and making sure that they are also having their providers refer folks. So like making sure their ECM providers are as quickly as possible checking in with the folks that they're the care managers for and getting them connected to community supports. So I see a question I'm going to answer now as opposed to waiting, about the difference between ECM and community supports through CalAIM versus those through HHIP. There isn't a difference, so I'm very sorry to have created that confusion. HHIP is, so ECM and community supports are CalAIM programs. It's CalAIM benefit and services. The reason they're coming up in the context of HHIP is that, as Irina mentioned, when she was talking about the metrics, one of the goals of HHIP is to make sure that these new CalAIM programs are being utilized as much as possible. And so some of the metrics that health plans have to meet and tell the state that they're doing well on is like making sure that people are connected to ECM and community supports. So hopefully that's clear. If it's not, Veronica, feel free to ask again or come off mute. But these aren't different programs. It's just that HHIP has sort of re-emphasized how important it is for COCs and health plans to make sure as many people are connected to these as possible. Does that help?
Actually, it really muddies things for me because the way our community is interpreting it is HIP is completely separate from CalAIM, and that they're two different funding sources.
That is true. HHIP and CalAIM are two different. They're two different programs. The connection is really just that in order to get HIP funding, one of the things health plans have to demonstrate to the state is that they are doing a good job connecting people to ECM and community supports. So they are separate funding sources, but health plans have to be able to show the state, like, we're getting people enrolled in ECM, we're getting people enrolled in community supports, and we're actually delivering those services. So that's why it's coming up in the context of HHIP, but they are separate. It's just that HHIP is one more way to incentivize plans to basically do a good job with that.
So what these managed care providers are trying to do is maximize the CalAIM, and they get incentivized through HIP if our community does that.
Yes.
Okay.
It's one of the things.
It's one of the things. Yeah.
Yeah. So
okay, that's one piece. Yes.
If you improve your HMIS, you will get more incentive funds. If you fund something that participates in street medicine and homeless service collaboration, you may get more incentive funds. And one of the main ones is these two new housing related services. So they're leveraging this ARPA fund, which is what's funding HHIP. It's the last of the COVID pandemic funding. They're leveraging it to try to quickly and immediately incentivize the managed care plans to get their members these new, really important housing related services.
Got it. When the managed care providers, they're the ones that receive the incentive, right?
Yeah.
How is that used?
We're going to We're going to get to that in a little bit more, but
Okay.
that's a good question. I mean, essentially, yes, the health plans are the ones who get the incentive funds directly from the state that are earned. But the idea is by requiring the health plans to work with their COCs in order to like have the information they need to prove that they deserve the funds, that part of that sort of partnership is an agreement that those funds will get reinvested in the community, including in things that the COC is like in charge of or overseeing. So we'll get to that a little bit more detail and kind of the specifics of how we might recommend some of that, but that's a very good question. And it's something that a lot of communities are in various points of figuring out with their local plans.
Yeah, and even now you'll find a variation between a community where the managed care plans are investing in communities in order to meet metrics without incentive funds, and other managed care plans who are waiting for the incentive funds to really make investments. So you'll find a wide range between those two things.
Yeah. But yeah, we'll definitely circle back to that, Veronica. And if we don't fully answer your question in like later part of it, we'll come back to it for sure. All right, great. I'm glad you asked that question. I'm sorry that we confused you, and I'm glad that it seems like at least on this, the difference between the Calium and HHIP that we're provide some clarification. So thanks for bringing that up. All right, we just have a few more slides on the maximizing enhanced care management and community supports. And as a reminder, everything we're presenting today is sort of a higher level overview of the more detail that'll be in the tools that are available on our website. So this maximizing ECM and community supports is one of the tools. So some of the tips, we've covered a couple of things that we would suggest, for COC side stakeholders, but some additional tips for maximizing these resources, these Calium resources, are things like we mentioned that for ECM, and this is largely true for community supports, if not entirely true, the referrals can come from essentially anyone can refer essentially for ECM and community supports, but the processes and the forms that are used for those referrals may differ both across community and across health plans. So making sure that you're connecting with your health plan to understand what referral forms they're using or what the referral processes are for making referrals. It will be a different process for enhanced care management than it is for community supports. And unfortunately, for some plans, they might have different forms. The process should be the same, but they might have different forms for the different kinds of community supports because there are different, populations of focus and eligibility requirements. Mostly that's the reason. But so making sure you're aware of and have access to the forms and the processes to actually make referrals to these two, the benefits and the services, is really important. If there is more than one managed care plan, Medi-Cal managed care plan operating in your county, asking them to coordinate with one another and ideally even agreeing on like a central form, especially for enhanced care management, and if possible on community supports, can be really helpful. Essentially just any way that you can work with them to try to persuade them to streamline and simplify the process for making referrals, regardless of which plan folks are enrolled in, the better. I know of at least one community where the 5 different health plans operating in it did agree to one single ECM form that all of them use. You still have to send it to the particular MCP, but it's the same form regardless. So there is precedent for that. But we would really recommend, to the extent you can have if you have multiple MCPs, to sort of have them coordinate with one another and explaining the importance of why simplification is so important. We have a couple things in the toolkit that will be, that's going to be available soon to help with some of this. So one is to collect the referral information. So basically, especially if you have more than one health plan, but even if you don't, that kind of will help you sort of organize the information of, this is the form, this is the referral process, like this is the email address you use or the fax number or the online portal, whatever their process is. It can kind of just help you collect the information once you have it, to have in one place to share with providers and folks who are experiencing homelessness if they're going to be making their own referrals. So there is that template to kind of just help you, once you have the information from health plans, kind of collect it in one place and organize it hopefully in a simple way. And then the other kind of tip relating to this is similar to ECM for community supports. We talked about this a little bit in response to that question, but understanding which community supports each of your local plans is offering. And again, to the extent you can get them to provide the information on who they have contracted with to actually provide those supports is really helpful. To be clear, the health plan will assign a provider. So knowing who the providers are can be really helpful, but when you make a referral or someone is referred to a community support, the health plan will make the decision of which contracted provider they'll get connected to actually deliver that service. And there's a tip related to that in just a sec on the next slide, I think. So in addition to kind of just those sort of very basic tips, we also have, and again, there's a little bit more detail in the tool, but wanting to share with y'all some topics that we think are good to discuss with your local managed care plans. Some of these are kind of referenced a little bit already, but this is essentially, a lot of this is in the name of simplifying and streamlining and making the referral and the connection process easier. A lot of the processes that exist that plans are starting to use for these are kind of similar to their usual doing business. And so kind of making clear and talking with your local plans about why, especially for folks who are in these populations of focus, especially people experiencing homelessness, and especially folks who are unsheltered, why it's so important to make sure these processes are as simple as possible, not just for the good of the people that we're all trying to help, but also if you need to tie it back to, you know, the HHIP metrics to like remind them that the more people you're actually able to get referrals for and to connect to these services sooner, the more incentive funds they can draw down through HHIP. And so kind of using that as a carrot for trying to come up with consistent and streamlined and simple processes are really helpful. So that includes things like, again, we kind of mentioned trying to simplify and coordinate across referral forms and have, you know, as few referral forms as possible to make the actual process for making referrals as simple as possible. So talking through with them like why it's really helpful to have those simple, what could be, if you kind of ask them what their process is, I am sure you will have some ideas about ways to make it simpler, both for their sake and yours. If they're requiring certain types of documentation to demonstrate someone is eligible for a particular community support, for example, that's another thing to ask them what documentation they're requiring. And again, I'm sure there will be lots to talk about in terms of making that as simple as possible. Again, because some of it will be sort of their default documentation that they require for things. And some of it might not be necessary to actually show eligibility. So if you can explain if it's difficult to get certain kinds of documentation and it's not really necessary, you can kind of talk through with your plans ways to, again, strip down to the really what's absolutely needed and the best ways to actually provide that documentation along with referrals. Talking about the actual like timeframes and steps, again, kind of leaning back again on the sort of HHIP metrics and trying to encourage plans or kind of remind them that the simpler they can make this, the more referrals they can get and the more people they can serve, and thus more HHIP money they might be able to draw down. So to the extent that their timeframes, like the time from receiving a referral request to actually matching someone to a provider and kind of every step along the process, they probably have, you know, particular amounts of time that they kind of work with. And so it might be that you can talk with them about, you know, even if it's just for people experiencing homelessness, kind of quickening that timeline a bit so that there's less time between referral and actually getting someone connected. And then the final thing on this slide that we'll mention is the follow-up protocols for once a referral has been set, we've seen has been really, really important in communities that folks are getting referred to enhanced care management, for example, but then the providers who are helping people make that referral are not getting any information about whether the referral has gone through, or if so, like who the enhanced care manager provider is. Or, you know, oftentimes if you're helping someone to make a referral for this program, you're also probably would be able to kind of do a warm handoff to their new care manager or their community supports provider. But that information, if it's not coming back in a like methodical way or consistent way, can be really tricky. So we'd also really recommend talking with your local managed care plans about the actual, like making sure there is a consistent referral, like a follow-up protocol, things like for folks that the COC or COC providers are making referrals for, making sure that the health plan is then has something in place, like a protocol in place to provide an update on what the referral status is, to actually maybe follow up with the COC or the provider if there's documentation missing that would keep the referral from actually going through, making sure that the health plan has something in place to actually confirm when someone has been enrolled in either ECM or a particular community support and approved for it. And then really critically, once someone is actually like assigned or connected with an ECM or a community supports provider for the health plan, either themselves or those providers, kind of requiring those providers to reach back out to the COC or, you know, whoever helped them make the referral to make sure that connection is actually made, so that there can be some warm handoff or even just assistance in then providing the support to the person that was referred. And then this final set, one of these was what I alluded to earlier, but some things we have suggested, again, for topics to discuss with or sort of work with your local managed care plans on that are specifically intended to ensure that both ECM and community supports are actually successfully implemented, specifically for people experiencing homelessness. One is discussing the potential of matching Medi-Cal members that are experiencing homelessness with providers who have experience working with people who are experiencing homelessness, especially unsheltered. So when we were talking earlier about finding out from your local managed care plan who the community supports providers are in your community that they're contracted with, if you notice on that list, like none of these people participate in HMIS, like none of these people are COC members, that's definitely something to talk with them about, either so that you can work together to try to get more COC providers to become contracted community supports providers. That's on one of the bullets too. Or at least there might be some COC providers or experienced providers on that list, and just kind of making sure that they have something in place where if someone is experiencing homelessness and gets referred for ECM or community support, that the provider they're matched with is someone that's going to be a good match for them. And it's not just kind of randomly coming off their list of providers. So because some health plans might have a kind of automated process where they sort of take turns going down their provider list, and anyone who has capacity might get matched with someone. So making sure they're aware of the importance of connecting folks to providers that make sense for each person can be really helpful.
Monica had a question about are CS or ECM providers required to use HMIS?
No. That's a good question, but also a pretty simple answer. The answer is no. There's definitely work. Yeah, I see your sad face and don't disagree. I mean, that's another benefit of trying to get as many COC providers who would be a good fit to be community supports providers, and maybe even ECM providers. That's, not just because they participate in HMIS, but that's another really good point, is the more people that you have that are already plugged into the COC to be providing these services, like it's simplified for a lot of reasons, and that's exactly one of them, Veronica. The other thing, and this probably shouldn't be a hard sell for most health plans, but in theory, if someone were to be referred to multiple community supports, they could get a different provider for each of those community supports. I think most health plans are probably not doing that, but that's just another thing you want to make sure that you're talking with them. Like if you're talking with your health plan, I think a good just sort of overall topic is, how do you decide who gets matched with which provider, which community support provider, for example, and let's talk about the ways to make sure that that's that like makes sense for the folks that we're talking about. And then the last two bullets on here are talking with your health plan to figure out, and probably this is information or expertise coming from you all, but really helping them to understand like what are the most needed community support services among folks experiencing homelessness. Again, we mentioned that plans have the option of selecting which of the 14 community supports they're going to offer. And so once you have a sense of which ones your health plans are offering, if you would suggest to them, because of the need that you see, that they should really prioritize offering additional community supports, that's something you can talk with them about. It's also really helpful in terms of thinking through when to really target referrals for certain community supports, like when it makes sense to connect people to certain types of community supports. And again, just making sure they have a better understanding of which of those supports is most needed by the folks that you're working with will be really helpful for them. And then on the other side, making sure that working with your health plans to figure out who on the COC side it makes sense to provide kind of training or education around what community supports are available, how to make referrals, like who it makes sense to refer. And that might vary. So it might not make sense to train every single provider and tell every single provider you should always refer everyone to housing deposits, when that might not make sense depending on whether the person is likely to have housing lined up. So just kind of talking with your health plan, your local MCPs about what information and when to share via trainings or education or otherwise with your COC providers to make sure that they're aware of these resources, that they know how to help people refer to them, and just to make sure that facilitating those referrals can be as successful as possible.
Sarah had in the chat a little bit of comment during when you were talking about making sure they're streamlining one CS provider for multiple CS, and talked about duplication of benefits. And it made me think that one of the things that we've been really advocating for with homeless service providers is if they do housing navigation, that they really should be reaching out to their managed care plans to see if they can become community support providers. Because the ideal situation is let's say you're homeless service provider A, and you're doing, you have 5 case managers who do housing navigators, and you find someone is a member of managed care plan A. You can go ahead and bill for that directly to the managed care plan and get not only help do their work plan paid by the managed care plan, but also get them access to the housing deposit. So you come up, you do some housing navigation, you come up with a housing plan for them. They are ready to be, they have an apartment ready and they need to put first and last month's rent down. The managed care plan can pay for that through the community support. And so the more you all can talk to your providers about becoming community supports, not only is it beneficial to you all as a COC in terms of using healthcare dollars and freeing up other COC funding, but it also just streamlines and facilitates the trusting relationships that you already have with folks in the homeless system of care. It facilitates being able to have access to funding from the housing deposits that you don't have traditionally in the COC. So there's a lot of great opportunities. And if I was going to say anything, the 2 paths I would prioritize is how to make referrals, and then identifying some key partners who are part of the homeless system of care to take a stab and try to be a community supports provider.
Thanks, Julie. Do we have other questions about community supports or enhanced care management, or how to make sure your community is maximizing those? And again, for all the things that we are suggesting, there are lots of reasons to want to connect people to these resources, but in the context that we're talking about, and like the focus right now for this calendar year can really be, if you have a health plan that is a little bit reticent to talk, or isn't quite, like, you don't feel like what you're sharing with them is kind of resonating, the reminder that the better this goes, the more likely they are to receive a better score on those the ECM and community supports related HHIP metrics, and therefore get as much of their HHIP potential allocation as possible.
Just a quick glance before we move to the next one. If you all could just put raise your hand or a thumbs up or something if you've had a member who you've referred for ECM or CS, or of other homeless system providers who have done that, that would be great, just to see if this is happening. Or awesome. One of you.
I should clarify that I made the referral, but it was never followed up on. So I sent it to a black hole. Nothing happened.
We'll come to office hours. We can troubleshoot with how to rattle the hole.
I'm feeling really jaded.
Yeah, I think the other thing this kind of thing is always hard, like working with across systems on new programs, right, is always really frustrating and like frustrating for, the black hole reasons and others. I think the other thing I'll say is, for enhanced care management and community supports, these are brand new programs. And so there's a reason that, DHCS through HHIP is, among other things, trying to incentivize health plans to kind of get it together when it comes to rolling these out. But they are very new. And so on the one hand, that's not particularly satisfying because you're still trying to help your clients. But I think it's just a little bit of an explanation. And it also hopefully means that it's not that the health plans are not willing to kind of work with you or try to make this processes better. They're just trying to figure it out themselves and kind of get it all going for a pretty enormous number of people, because these aren't just resources that are available for folks experiencing homelessness. It's just that people who are homeless are one of the populations that are eligible for these. And so the health plans are all trying to figure this out and kind of scrambling a bit to get this going. And so on the one hand, that means it might be a little harder to get their attention, but on the other hand, they hopefully are will be, at least some of them, like very grateful for any guidance you have or like thoughts on how to make it easier, especially for the folks that you work with. And so the more you can kind of couch your requests and conversations with reminders that you all want the same things, and it's to get these folks connected to these benefits, and you have very unique knowledge and relationships that can help them make it a little bit easier on themselves. I know that's easier for me to say than to happen on the ground, but I just wanted to at least say it. And Arena, I see you wanted to add something too.
Yeah, just to add, I think the communities where I'm working, it's a challenge for COCs to get these connections and these referrals going. But we have seen that a lot of the MCPs are really willing to talk about, well, what's going well? Like, why is that not working? Who is the referral person? Like, do we need to circle back and do some work on our end to make it happen? As well as the referral processes in these various forms. Like some MCPs, you know, just because the referral process is there doesn't mean that you have to kind of accept it and go with it, right? It's a conversation that can happen with MCPs being able to and being really willing to accommodate like an easier process, for example, or change who they're contracting with. So it's really worth having those conversations and relationships on the local level with your local MCPs to see how far they can meet you sort of at least halfway on making these things easier for you.
Yeah, well, our COC lead is what I do, but I'm also in social services that operates Medi-Cal and has the relationship with our managed care provider. And it's completely siloed staff that interact with our managed care provider. And the COC piece of it is an afterthought. And I'll come into it and I'll be like, well, all of these decisions have been made and none of them work for anyone that's experiencing homelessness. And I'm kind of almost at the point where I'm like, okay, just let me know when you need a report and I'll just back off, because they're not interested at all in growing it. You know, they want to do the CalAIM and they want, you know, and that's all good and well. I just don't know how to not force my way into the conversation, if that makes sense.
Yeah, Veronica, we're going to have an opportunity. We're going to have opportunity to do some TA in some communities, and so definitely keep an eye out on that, because I will say that having Homebase as a understanding both systems and kind of doing some of that translation and knowing when to push and when not has been helpful in some communities. And I'll give you an example. One community we worked with, we had 3 MCPs in that community, and we asked them who their ECM provider was. And they're like, oh yeah, we have an ECM provider. And they told us who it was. And we're like, they don't do anything in this county. And they're like, oh yeah, they assured us they did. I'm like, well, that would be good to know about. And then we got a phone call 48 hours later that we were right. That provider does not provide services in the county that they were contracted to provide ECM services. And so just asking the question and saying it made the managed care plan aware. And it wasn't bad intentions, but they're not on the ground in that community and had no clue that when they were told by the provider that they serve that community, that it wasn't a reality in the homeless system. So there's a lot of work that can be done. And you know, we have that roundtable to help you all support each other as well, and to talk about what things are working and not working, so you can hear from each other and collaborate a little bit more. But I would say, don't throw your hands up yet. That's the whole reason we have this project, is to help you not throw your hands up yet.
Yeah,
Okay.
and I know we've, in addition to the roundtable that Julie just mentioned, that the other thing is, as I know we already said this, but that's part of what the office hours that we have scheduled later this week and next week are for too, is to have a little bit of like more real-time kind of help troubleshooting. So I hope you're able to come to at least one of those. We can talk through some of that there too.
Thank you.
Yeah. All right. I'm going to move us into the next topic, which is our last. And again, we'll have more time for questions too. So if folks are still wanting to ask questions about even ECM or community supports or the metrics, anything we've talked about, we'll have more opportunity. What I'm going to move us into now is the final like tool that we're really kind of diving into, or at least providing a little bit of information on. And this relates back to a question we got earlier about how to, like, what happens with the money once the health plans get their HHIP funds. So we do have a tool that's focused on what we're calling expenditure planning, which is really all about like looking ahead, like what does happen with the HHIP funds that are received by health plans in different communities. So in every, just as a reminder for folks, I know Irina mentioned this as part of her when she was talking about the metrics, and of course there's information in our HHIP overview materials on our healthcare website that go over this too, but all the MCPs were required to submit to the state an investment plan, and they were required to, or they were meant to work with their local COCs. So hopefully you all had some connection with them while they were doing this, but the investment plans were really focused on what investments are they going to make in their community in order to be able to meet the HHIP metrics, which then will allow them to get HHIP funds. So what this tool and what we're talking about for the next few minutes is kind of a step beyond that, which is more looking forward into the future, like beyond the metrics, beyond the HHIP time period, but kind of what are some longer term ongoing investments and ways to really partner across the COC and the MCP, and some help in sort of guiding, or some guidance for creating that process, or kind of laying the foundation for that long-term ongoing partnership and investment. So one thing we want to note that is a little bit of a wrench in some places, but wanted to at least make sure people are aware of it, is that the state has limited the number of MCPs in some counties. And so moving forward, not all the MCPs that are current, if you're in a county that has multiple MCPs operating in it, not all of those MCPs might be continuing to offer to be Medi-Cal providers in your county. And I don't know whether that information, like the details of which plans will be moving out, is available yet, but the health plans at least know it. So if you're working with multiple health plans, knowing which ones will continue to operate in your community in 2024 is obviously important to know. But essentially we want to, make sure that we have guidance for COCs to work with their health plans to make sure that the HHIP incentive funds that are earned and are drawn down by the health plans is actually going towards where it's needed most, and where the HHIP program is meant to have it invested, which is back into the community to prevent and end homelessness. So there's an opportunity to really leverage these incentive funds that the health plans are going to be drawing down to fill gaps in housing need and other gaps where other funding, whether it's state or federal or local, is either non-existent or really limited. So that's what this tool is really focused on, is again kind of guidance to help COCs work with their health plans to develop an expenditure plan, which is essentially like the plan for what do we do with the HHIP money that we're going to get. So some of the incentive funds that have, or some of the HHIP incentive funds that may be awarded might already be spoken for as part of the incentive plan that you put together with your health plans if you were part of that process. But there will be some amount of HHIP funds that the MCPs will hopefully receive in the future that they, and ideally working with you all, need to figure out what to do with and what to spend those on. So coming up with, so that again, this tool provides more detail, but just as an overview, the idea is to work with your MCPs and talk with your MCPs to develop a plan that considers things like what's the total amount of incentive funds they're eligible for and that they think they're likely to get, assuming they meet the metrics. And some plans will even, be willing to share with you, we're not quite meeting the metrics fully because some of them are very hard to meet, frankly. But this is our best guess at the amount of HHIP funds we're going to actually get. So talking with them about that. Kind of talking with each other about what other sources of funding are available, including things you probably or maybe already talked to them about. But especially if there are newer sources of funding or if funding has changed, kind of just putting it kind of all on the table and talking amongst yourselves, in addition to the HHIP funds that might be coming in, what are the other sources of funding? What can they go for? What still needs funding? What are the activities that you have already identified in your previous conversations, especially in the context of investment planning, if you did that with your local health plans, that have already been identified that you either have kind of seen that additional investment has really helped, and so you want to contribute, you want to add more investment to that, or really, obviously, really importantly, what still really needs to be funded? What are the continuing gaps and needs in your homeless response system in your community that there isn't currently funding for, that even the HHIP even the investment funds that health plans might have been already talking about adding to won't be enough? What are the biggest gaps and needs that you can use this really critical, one-time but very flexible funding for? So then this just has a few really key considerations in terms of what you want to include in your conversation with the health plans as you're talking about how to spend the HHIP funds that come in. Things like whether those new funds should be invested into existing activities that just need more funding and are kind of proven to really work well and can make an even bigger impact with more funding, or if there are either other needs or new things you want to test out that you think could really make a big impact, but there's not another good source of funding for them. So conversations about where you want to really focus any additional funding, what existing strategic plans or other plans that you have already in your local community that you can reference for, again, new ideas for things that are still need additional funding, that are difficult to fund with other resources. if there are particular subpopulations within the community that are being underserved or not being served at all, that new funding can really be kind of focused on supporting. And the other thing is, as a reminder, I think it's really helpful to think about when you're making these plans or having these conversations, the specifics of this funding, which is, again, it is very flexible, probably more flexible than most other funding that you have. It's also only one time, so that's a really key thing to keep in mind, that it probably doesn't necessarily make sense to make a plan to invest HHIP award funds into an ongoing service need, for example, because it's a one-time funding pot. So thinking about the best ways to leverage this one-time but really flexible funding into more permanent investments. So for example, an MCP could invest in like rehabbing or renovating a building that a homeless service provider could then operate as PSH moving forward. So there's ways to think about ways to invest this one-time funding into projects that are more permanent, but just like being clever and really thoughtful about what the one-time funds can be used for, that there aren't other resources available for. And then we just wanted to give a little bit of this is in the toolkit a little bit more, but there are a couple of tools that are essentially just like ideas for ways to kind of organize your conversations or the things that come out of your conversation. So there's an initial stages planning tool. They look very similar, excuse me, but there's an initial stages planning tool. So when you're talking with your health plan and kind of some of the key considerations we were just talking about, you can identify priority areas, which can either like be kind of lifted over from your investment plan or new areas. And then you can kind of flesh out particular programs or strategies, kind of come to a consensus on what's the gap or the need that you'd actually be addressing with that. There's additional information you need or like really specific next steps. And then we have discussion participants there, because we found in some communities that putting together a plan between the COC and the MCP, even if you have opportunities for people to contribute, if you then are sharing the plan with others and you get questions about, well, who made these decisions? So making sure you're aware of like who is part of the discussions can be really useful. And then we also have just a very simple actual like template for the expenditure plan that just has really basics like what's the strategy or program you're going to fund, you've agreed to fund with HHIP award funds, description of it, how, like what's the actual amount, either the percentage or the actual dollar amount if you're comfortable, who would be actually getting the funding, and if there's any kind of like process that you need to figure out. And then of course kind of things that you'd want to put in most plans like this, which is anticipated impact, right? Like what your goals are, what the performance metrics are, and what the timeline would be. The other thing about the funds is, in addition to being flexible and one time, there's not an expenditure deadline for them. So there's a deadline by which the state has to get this money to the plans, which is why this timeline is so tight for HHIP. But once the money is in the hands of the health plans, there's not an expenditure deadline. So they might want to spend it by a certain time, but it's pretty flexible in that way too. So the timeline can be a little bit longer term if you kind of want to plan for something that's a little bit of a longer term project.
Yeah, I was just going to say that we're working in a community where they just finished a strategic plan and they don't have a COC staff person in that community because it's part of a bigger COC. And so the managed care plans agreed to fund for the first 2 years a staff person. So beyond the amount, beyond March 2024, they made the commitment. We'll leverage these funds to stabilize your staff, and that's going to be huge for that community.
Thanks, Julie. So again, we have a few minutes for questions about this expenditure planning concept. So I know it's not an easy answer. I think it was you, Veronica, that asked the question about how does this money get spent? Technically, it's how the health plans decide to spend it, but there are ways for you to leverage your kind of power in this situation, which is reminding them that, DHCS has tried to put in a lot of requirements, including with the metrics, to kind of make health plans realize how valuable COCs are as partners in this work. Again, while the funds are flexible, the idea is that the funds will be used again back to like invest back into the community, and specifically in the community's homeless response. So there's definitely ways to kind of leverage that to try to work with the plans to put together an expenditure plan that actually makes sense. So some of the money will probably stay with the health plan, but there are definitely like ways to talk through and come up with strategies and programs that would be really good investments for the health plan.
And also, yeah. Sorry to interrupt.
No, go ahead.
I was going to say that one of the whole reasons these programs and this partnership across homeless system and healthcare is because y'all are serving the same populations, and it's costing both systems a lot because there's lack of coordination, and people who are homeless who aren't getting access to healthcare are staying homeless longer, and people who are homeless who aren't getting access to housing are sicker. And so the idea is that if you really want to talk about the bottom line, is that coordinating will save the managed care plans money by having the people that they serve get housing, you know, and be healthier. So it's reminding them of that too. And it's a whole premise of this partnership isn't just to get you to work together, but because there's real evidence that the overlap and social determinants of health and addressing them together has great impact on people's housing and health stability.
Yeah, thanks, Julie. And this isn't a guarantee yet, obviously, but I think it's fair to think that if the state finds that this program has gone well, that if they have additional funds in the future to offer for something like this, there might be future opportunities for similar kinds of incentive funding, and presumably they would look more kindly on health plans who are participating, like partnering well with their local COCs and kind of following along with the guidelines. There are definitely, I don't think any of us want to suggest that this is simpler than it is. And I know we've talked in a couple ways about communities where it's been trickier. There are definitely examples in communities where the health plans are really coming to the table as real partners in this and like working with the COCs to come up with expenditure plans where they're literally saying, we're going to give X amount of money of these HHIP funds to the COC to do X, Y, and Z. So it is, while it is not like, we don't want to sugarcoat and like make it seem like health plans are all fully on board and they're just going to agree to hand over money as long as you ask nicely. There are definitely plans that are kind of coming to the table, really. And so thinking through ways to make clear why it's good for everyone involved. There's definitely a lot of great potential for coming up with some plans to get some of these funds to do really good work to help supplement what you're already doing with your COC work. Any other questions about the expenditure planning? Again, this is the tool in the toolkit that will be available this week. All right, I think I'm going to hand it back over. Oh,
yeah, I think it will be ready by the end of today.
Yeah,
we have it in hand while we've been chatting, so that's good news.
Thanks, Julie.
Yeah, so I'm going to just tell you about a few data, and data sharing has been a big topic, and I think that everyone understands data sharing in a way that, you know, the metrics are a little unclear, ECM and community supports are a little unclear. The data sharing is clear, it's just the path how to do it. And so I don't think we didn't plan on walking through these in particular. They're very self-explanatory, but we did want to highlight some of the tools that will be available. So the first one is a actual sample data sharing agreement. And it's built on some great work that happened at Benefits Data Trust around data sharing for public benefit programs. We use their model on bilateral data sharing because we feel like it shouldn't be a one-way unilateral. You're providing as a homeless system of care great information, the managed care plans, but there is some detailed information that would be good for you all to get back. Like it would be, as Julian said earlier, nice to know who the ECM case manager is, so you have a contact name. It would be nice to know that they're getting ECM, or that they are accessing community supports, or they have a housing navigator already in the managed care plan. So that kind of information will be really important. And you know, probably all of you would say you don't know if your members, the people you're serving, are members of a managed care plan. So even just knowing who of the people on your by name list actually are Medi-Cal members could be a huge piece of information. And I'm just caveating that this isn't legal advice. You'll want to still base this template and then work with your legal advisors. But what it does, if you're working with county council or folks who don't normally do this, it gives them a nice basis to then start and then adapt based on you know, their comfort and their level of legal understanding in your community. So that's available. That will be available today or tomorrow. And then we talk a lot about, and there's this pressure to do some data sharing with HMIS, but also some data matching. And so there's opportunity to do some data matching that may not be high tech, as doing like the two systems talking with each other through APIs and webhooks and all the stuff that we hopefully don't really want to talk about. But this sample data matching workflow has text and visualization about how to implement data matching across the COC and the managed care plans, you know, in the short term to be able to help them meet their data matching metric for DHCS. And then the last one is thinking in the bigger picture. You know, a lot of us don't get an opportunity to change HMIS very often, but a lot of the investments coming from managed care plans are to improve HMIS and upgrade to a higher functioning vendor. And it's an opportunity to add new data fields or new data elements that would help deeper collaboration. And so this is some ideas about new data elements that either may already be in some HMIS, but may not be. And we found that some of these things are in the notes. And so you can't search by them. You can't find them easily. You have to go read every note. So these are some suggestions about new data fields or new data elements to collect in HMIS to enable greater collaboration across the managed care plan and the homeless system of care. So next slide. Any questions about those data documents? We'll go to the next slide. We've mentioned a couple of times, we are offering office hours. They're unlimited. So what it means is you can come in and ask, read our materials and ask questions about them. Come in with a question that you have, a trouble, a hurdle that you're trying to overcome and you want to brainstorm. They are this Thursday from 11 to 12 and again next week on Wednesday from 11 to 12. And Jillian put in the chat a link to directly register for those office hours. All of you should have our email, which is healthcare@homebasecc.org, which I'm typing in right now. If for some reason you don't have registration, you close this before the chat happened, just drop us a note. It will cover any material you want to cover on HHIP. So we're happy to go through these toolkit materials, but if you come with an HHIP problem that we aren't talking about or that you're having, just come. And if we say, let's do this offline, we'll tell you, let's do this offline. So definitely come with your questions. And then I just would urge you, go ahead.
Julie, sorry, can I just interrupt for 1 sec? Just based on that question, I just wanted to clarify, we're not going to present any slides or information on the office hours. They really are meant to be like additional opportunities for Q&A, or like actually if you have things that are coming up in your community, like Julie said, in the context of HHIP, we can kind of talk through them. So they're not, we won't be presenting slides, they're actual office hours in the way you maybe think of office hours, in that like come with your specific questions about, or like, again, like Julie said, either about the toolkit or the tools, or if just you want to talk through some things that have been going on with HHIP in your community. Thanks, Julie. Sorry, I didn't know.
And if there's one person doing a lot of questions, if there's one person doing a lot of questions, we might say, hey, can we do this offline? We want to give everyone a chance. What I would say in advance of when you're coming to that, definitely if you want to get more familiar with the difference between ECM and community supports and HHIP, I'd read our materials that are currently on the website so that you can get everything you can out of those and maximizing our more troubleshooting TA in those meetings. And then we have all of your names from today. And so we will specifically send to you all out the announcement that that the toolkit is up on the website. It should be up there today or first thing when you get in tomorrow, but just in case it's not, you don't see it, you can reach out to us at the healthcare@homebasecc.org. And if you're not sure we have your email, feel free to put it in the chat now. We will follow up with you all for that. So the next slide is just a rehash of all the different materials that we already have in place. If you have coworkers that would benefit from hearing about this, if you have colleagues in the homeless system of care, then these might be some materials you want to share, but we also will be posting this webinar so that other folks in your COC who might benefit could access this webinar as well. So any questions or clarifications before we wind up?
You may have answered this already, but will the office hours be recorded?
That's a good question. Yeah, probably
think-
not, because they tend to be
Okay.
more working sessions and they're meant to be, but we might take some, we usually take some notes during them for our own benefit. And so if there are like, I don't know, bombshell things that happen that we really think are important to share with folks, we can figure out a way to share those out, but we usually don't record them because they tend to be more community specific. And also some people are a little more reticent to share complications when they're being recorded. So
I understand that. I'm just booked for during both days, so.
Rana, you can reach out. We're also open to getting just, one-off questions if that would be helpful. We're going to be putting out some, I don't know if it will be an RFP, but some kind of opportunity for doing TA. And so getting some light lift TA through email is okay too. So feel free to at least try. And if it's more than we can do, we'll let you know. Okay, any other questions? I would definitely bookmark healthcare at homebaseccc.org/healthcare and check it out later today or tomorrow. And you should have access to the toolkit by then. And we're interested in hearing if it's helpful, if it's missing things, if there's things that you thought should be in there that aren't in there, we want to hear, because we develop those based on our on the ground work in communities. And so if there are different needs or different documents that are needed in communities, we want to hear about them because we may create new tools. And sorry, I went off camera because I'm having bad stability on my Wi-Fi. Okay. Well, if you want, we can stand for a few minutes if anyone has any other questions. Otherwise, we hope to see some of you in office hours and get some feedback from you all about how the toolkit is landing in your communities.
thanks so much, everybody.
Thank you.